Good morning, everyone. Today we're gonna discuss genetics and pediatrics, and it holds a lot of weightage and have many important points regarding some of the disease. So we can start with chromosomal abnormalities, and the first one is Down syndrome. I'm sure you all have heard it many times in your curriculum. It is trisomy 21 that we know, the most common. Okay, so what we're gonna learn about trisomy 21 Down syndrome is it is the most common malformation, and 94% have this trisomy 21, and the risk of recurrence is 1 to 2% and increases with the maternal age. 4 to 6% around 4 to 6% around is due to translocation, which are new and new mutations. And the 94% we already know is with full trisomy 21, that is non-disjunction due to. And this was about genetics of trisomy. Now what findings are gonna find in the Down syndrome? So what are the findings? Because questions always come on findings. They will give you the finding and you have to conclude that it's about Down syndrome and answer the question as it asked. So what can we see in the findings? We can see upward slanting palpebral fissures, speckling of iris, that is called brush-filled spots, inner apicanthal folds, and there is a small stature and mouth open with a tongue protrusion. There is a mild microcephaly, and the neck is short and have flat occiput, and metacarpals and phalanges are short. And one important point that sometimes and means always present in its finding are single palmar crease. So this is a very important finding. Other things like hypotonia, and there is hearing loss. It can be any sensory, neural, conductive, or mixed. And there is primary gonadal deficiency. There is cardiac anomalies. And in the cardiac anomalies, the most common are endocardial cushion defects. And then we can say VSD, that is ventral septal defect, ventricular septal defect. And then it can be, we can say PDA, that is patent ductus arteriosus. And in GI, if we go for GI, what's seen in GI is duodenal atresia, very important, Hirschsprung disease, and atlantoaxial instability can be seen. And in metabolic disorder, we can see hypothyroidism. Hypo. Okay. So these were the main findings that we can see. And what other in blood we can see, ALL is very important. And in brain and in cognitive, we can see there is intellectual disability. And this disability can be variable, can be of any severity. And these were the findings in Down syndrome. And what is the natural history? So natural history, like a major cause for mortality is mainly heart disease. Okay, heart disease are main cause of mortality, and muscle tone improves with the age. And one thing is very important, that is early onset Alzheimer's disease that is associated with it, and the rate of development slows with the age. So these were the important parts of trisomy 21 or Down syndrome, as we call it. So what is the main thing that you have to remember? ALL, you have to remember intellectual disability, you have to remember atlantoaxial instability, the heart disease causing the most mortality, most common being endocardial cushion defects, then VSD, There is a hearing loss, there is hypotonia, and on facial features, we can see the upward slanting palpebral fissures, brush filled spots in the that is the speckling of iris and epicanthal fold. In genetics, we already know 94% is trisomy 21, that is non disjunction, and 4 to 6% is with translocation. Now we come to our next part, that is trisomy 18, which is called Edward syndrome. So we know we learn trisomy 21, 18, and 13 together mostly and see the differences. So this is the second trisomy that is very important, that is Edward syndrome. So what is there in Edward syndrome? So it is the second most common of human malformation, and it occurs with age, maternal age, as is Down syndrome, the incidents occur more. And here also non-disjunction is the main genetic path that is being used in the mutation or the trisomy 18. And what are the findings that we can get? Findings which are important are growth deficiency, we can see intellectual disability, we can see low set ears. Okay, the ears are low set and malforms. There is microcephaly, there is micrognathia, that is small jaw, and there is occiput, which is prominent, and clenched hand is very important. In this, mainly there is index over third finger and fifth over fourth, and short sternum, and cardiac defects are similar to trisomy 21, like VSD, ASD, PDA, but it has cyanotic lesions also. And very important part is rocker bottom feet. That is very important. Apart from rocker bottom feet, you can see hammer toe. That is important. And one last important finding is omphalocele. I told you difference between omphalocele and gastroschisis and how to differentiate between them. So omphalocele is herniation, and it is mainly from through the umbilicus, and the intestines doesn't go back after maturing, and the main thing is it does have a covering around it. The herniated bowels are covered, but in gastroschisis no covering is there, and that is lateral to the umbilicus, the opening, and that is due to muscles being weak and unable to close the abdomen. Now trisomy 13. This was trisomy 18. The important points were heart defects were same, intellectual disability, main things clenched hand, and microcephaly, micrognathia, and low set ears, rocker bottom feet, and omphalocele. So just try to remember micro with it. So it will everything becomes small, like micrognathia, microcephaly, and the ears are low set and malformed, and there is intellectual disability. So like this, you can learn the points. So next is trisomy 13, that is also called Patau syndrome, and it is a defect in the midface, eye, and forebrain. So that is important thing. Midface, eye, and forebrain. So these three defects are there, developmental defects. So it involves older maternal age, as in trisomy 18 and 21, and it has some findings. So these three defects are there, so findings will also be like that only. So in brain, since there is forebrain development is not there, then holoprosencephaly and severe intellectual disability. And it also has micro in it, microophthalmia, microcephaly, and the things that is being added in this is cleft lip, palate, cleft palate, and post-axial polydactyly and heart disease are seen. And there is single umbilical artery that is very pathognomic. So cleft lip, cleft palate, single umbilical artery. So these are the main findings that we have gone through. So let's revise trisomy once again: 21, 18, 13. Down, Edwards, and Patau. So most all of them are associated with increased maternal age. As the maternal age increases, more chances of getting them. All of them are mostly due to non-disjunction of the chromosomes, and they have common heart findings. Apart from trisomy 21 has endocardial cushion defects more, and they have some specific findings to it. Some facial findings in 21 and hearing loss and single palmar crease. 18 mainly and micro everything, microcephaly, microgenetia, low set ears, intellectual disabilities in all three of them, and there is rocker bottom feet. Now in trisomy 13 we have three defects: mid face, eye, and forebrain. So forebrain there is holoprosencephaly, mid face there is microophthalmia, microcephaly, and severe intellectual disability. There is in the face there is cleft lip, palate that we can see, and there can be heart disease and single umbilical artery. So we are done with the trisomies. Next we'll come to a very important part, being Vager syndrome, that is Aniridia Wilms tumor syndrome. So it you can remember it with it occurs in the Wilms tumor type 1. So there are two types, type 1 and type 2. It is associated with type 1, and it is due to deletion of 11p13, and mainly it is Wilms tumor, aniridia, GU anomalies, and MR. So these are associated with A for aniridia, Wilms, GU, MR. And there is 42 association with the Wilms tumor is 45 to 60%. So there is this much chance of developing them if you have Wilms tumor type 1. So that is very easy to remember from the mnemonic, can be directly the name Wilms, aniridia, GU, MR syndrome, and deletion of 11p13. The next one is very commonly that we have studied is Klinefelter syndrome, which is XXY. So most common it is manifested at the puberty, and main thing like decrease IQ, or we say intellectual disability, and psychiatric issues, long limbs, that is very important. The upper segment to lower segment ratio is decreased, the ratio is decreased, and because the limbs are long, lower limbs, and we can see they are slim, so weight to height ratio is also low. And there is hypogonadism and hypogenitalism, and testosterone replacement at the age 11 to 12 years leads to hypergonadotrophic hypogonadism, that is increased FSH and LH and decreased testosterone. And infertility is the main part, gynecomastia and infertility is main that occurs in it. So it present with puberty mainly, because with puberty what happens, there is increased testosterone production, right? So increased testosterone production, your increased testosterone replacement from outside will, what will it do to the feedback mechanism? It will increase FSH and LH. And when they are increased, they will give positive feedback. They will give the negative feedback to the pituitary, and this will lead to ultimately decrease testosterone secretion. So that's why it is hypergonadotrophic hypogonadism. There is no problem in the pituitary. Pituitary is okay. That's why FSH and LH are increased. But the problem is in the testes. They are not developed. So they cannot produce the testosterone. So testosterone in the serum will be decreased because there is no making of it. And if you give it from outside, the testosterone, it won't what it will do, it will do a negative feedback and decrease the FSH and LH also, and will lead to then the functional decrease in testosterone. So what can we do in this case? So in this case, we have to directly give the testosterone therapy because pituitary is doing fine. It acts, the FSH and LH is being released. The testis is not making the testosterone. So you have to give the testosterone, exogenous testosterone for puberty, and that will help in the formation of secondary sexual characteristics and external genitalia. That's why they are infertile too, because of the hormonal and the testes being defective. Now we go to the Turner syndrome. Turner syndrome is that is one X chromosome is missing, and most likely the missing chromosome is from paternal side, and no maternal age is not associated with it. So what can we see in such type of females? There will be small stature females, and there is absence of one SHOX gene, that is short stature homeobox gene, that causes the embryonic regulation of skeletal system, especially in the arms and legs. So absence of one of these genes, that's why the stature is small. And the growth hormone and IGF receptor excess is abnormal. Gonadal dysgenesis leads to the streak ovaries, that is very commonly given in the question or asked. Streak ovaries. IQ average is 90, around 90. And the main thing is lymphedema, congenital. There will be puffiness on the dorsum of fingers and the toes. And your chest will be broad. There will be very wide space nipples and low posterior hairline. There will be webbed neck, and there is cubitus valgus at the elbow, and there is horseshoe kidney, okay, very commonly associated with it, and other renal defects can occur. Now cardiac, mainly bicuspid aortic valve. So instead of being tricuspid, it is bicuspid. And other thing is coarctation of aorta that occurs, okay. So coarctation of aorta occurs, that is narrowing of the aorta at the arc of aorta. Other things that can occur is mitral valve prolapse, aortic stenosis, and hypertension. Now, what we'll see in the history, there will be decreased height velocity with delayed bone age. So what we can give to this patient also? We can give the hormonal treatment only, because what? The pituitary and the CNS is fine. The ovaries are streak. So they are not producing any of the estrogen. Okay, so what we have to substitute? We have to substitute estrogen from outside. So estrogen treatment is done, and growth hormone can be given to increase the height, because there is a growth hormone and IGF, which is responsible for the effect of growth hormone in the at the target organ. There there is some defect in their communication here. Now the next thing is fragile X syndrome. Fragile X syndrome. Now, fragile X syndrome is fragile site on long arm of X in the affected males and some females which are carrier. So there is variable number of CGG repeats. So these CGG are trinucleotide. We can see 1, 2, 3 trinucleotide expansion in the meiosis to a permutation state, like 50 to 200. This is important for the passing on to the progeny. But if there is full mutation of the CGG, there is more than 200 CGG trinucleotide expansion, then there is epigenetic methylation. And we have studied the epigenetic methylation. The methylation is one of the process through which we silence the gene. So it silences the gene, and that leads to protein inactivation and full-fledged fragile X syndrome. More likely, meiotic expansion in future generation can occur with genetic anticipation. Anticipation is if a person has his father suffering from that disease at an earlier age than his forefather, then he is suffering at earlier age than his father. So this is anticipation. This is the particular trend, how it shows the anticipation in the genetic history. Now, X-linked dominant is mainly, it is X-linked dominant. It can occur in males with intellectual disability, and there is a lionization that occurs, that is random inactivation of one X chromosome. There is inactivation of one X chromosome. So males have X5, females have XX. So there is one X in males that is also inactivated, and in females there are two, so one is inactivated. So there are generally few abnormalities in female, but there can be some like low IQ, but it is more pronounced in male. And what are the findings? That mild to profound intellectual disability, learning disorder, depression, autistic like behaviors. Okay, you remember one thing I told you in the adverts, remember micro. So in fragile X, you'll remember large. Everything is large. Large ears, large jaw, long face, and large testes. So testes are also very large, mostly in puberty. And the term used for large testes are macroorchidism. Okay, and the lifespan is normally normal. Now, these were the chromosomal abnormalities that we saw. Some were trisomies. This was trinucleotide expansion, that is more repeated CGG units, trinucleotide units, and leading to the gene silencing. Now we come to some syndromes associated with defects. And first one is back with Widman syndrome. And in this, mainly the IGF-2 is disrupted at chromosome 11, P15.5. The P is the petite arm, that is the short arm. And so both copies of gene are expressed in it, which leads to overgrowth. So overgrowth occurs. So IGF we know, insulin growth factor, is responsible for the peripheral growth by growth hormone, and it has a lot of action on many tissues that leads to growth of that tissue. And since both of these genes are expressed, and so there is overgrowth, too much overgrowth. So we can remember the term in back women as macrosomia. Macro. So macrosomia, glossia, that is tongue, big tongue, and pancreatic cell hyperplasia, which leads to, what will it lead to? Pancreatic beta cells, they increase. Beta cells secrete insulin. Insulin increase, so it will lead to hypoglycemia. So other things like omphalocele is important. Hemihypertrophy is with increased risk of abdominal tumors like Wilms tumor. So what can we do if a person has this syndrome? So we can manage it by every 3 months. We can obtain AFP to look for hepatoblastoma. AFP is alpha fetoprotein to measure the carcinoma of liver. It's one of the marker that's increased in the liver carcinoma, and up to age 4 we can do that. And ultrasound to look for any Wilms tumor until age 8. So every 3 months, what we are doing, AFP and ultrasound abdomen. AFP for looking for the hepatoblastoma, and ultrasound for looking for any Wilms tumor, and we can measure it till 4 years, we can measure it till 8 years. The AFP by 4 years and ultrasound by 8 years. So this is mainly associated with Wilms tumor type 2. And the type 1 we have already seen it as Vager syndrome association and 11p chromosome deletion. Now we come to other syndromes like Prader-Willi and Angelman. We can study it by differentiating between them or comparing them. So Prader-Willi. One is Prader-Willi, one is Angelman syndrome. Now, mostly with deletion of Prader-Willi is with deletion of 15q11 to q13. Q is the arm of chromosome, the longer arm of the chromosome. So deletion at this, and what does it occur like? What is the deletion? Deletion of the chromosome. And what are the findings? The first year there will be poor difficulty with eating or feeding, and then increasing feeding and weight gain. Then there is slow height attainment that leads to the short stature. There is obesity and mild to severe intellectual disability, and there is food related behavioral problems like binge eating. And there is on the gross examination of the baby, we can see small hands and feet, puffy and all puffy, and there is small genitalia. There is hypothalamic pituitary dysfunction, which affects growth, thyroid and adrenal hormone. And there is kind of hypogonadotrophic and hypogonadism. So hypothalamic pituitary dysfunction occur, and life expectancy is mainly decreased due to the morbid obesity. So one thing to note here about the genetics is the same deletion causes both Prader-Willi and Angelman syndrome due to normal process of imprinting, which is epigenetic. That is change in chromatin and not the gene sequence. So epigenetic silence is due to hypermethylation of certain genes in either male or female germ cells. So allele in opposite germline are expressed, and therefore in the zygote this result in the monoallelic gene expression, so that from any imprinted segment there is functional haploid state. It is established in the germline and maintained in all the somatic cells. So just for an example to explain, if the deletion occurs in the male germ cell, then the inheritance is from the only expressed genes, which are maternal. So this is Prader-Willi. And if the deletion occurs in the female germ cell, then the inheritance will be from what? It will be only with the paternal. This is Angelman syndrome. And why this deletion occurred? Due to epigenetic silencing, due to hypermethylation. If we ask, the process is hypermethylation. So this is the example of imprinting. Okay. So now we can see the features in Prader-Willi. You just remember the male deletion. You can remember with the mnemonic, like there is P in Prader-Willi, so P for paternal. So paternal deletion occurs, and female is morely express the gene in all the gene cells and the somatic cell. So you can remember the child is always obese, and if he's obese, obese and he has some mental intellectual disorders, he's severe intellectual disability, and he has some binge eating disorders and small hands and puffy. You can remember with the diagram like obese and small hands.